I realize this is all a little bit out of order because we haven't yet had the case-based discussion on complicated cases in HIV prevention and STIs. But I'm Raphael Landovitz. I'm going to be giving that talk in about an hour. I'm at the University of California, Los Angeles, and I spend the majority of my time trying to both clinically and from a research standpoint, optimize the use of antivirals for both HIV treatment and HIV prevention. And what I've sort of spent most of my time on recently has been the phase 3 clinical trial of long-acting injectable cabotegravir for PrEP compared to daily oral Truvada that many of you may have seen the results of either in the media or at the AIDS 2020 conference. We are going to be talking about that study a little bit in the case-based talk, but this interactive session is going to be more of a whiteboard talk. I'm not going to be presenting at you, but I want to engage you all in a discussion of the clinical challenges and situations that you are all having in the clinic, as well as talking in a little bit more detail about long-acting PrEP if people have questions about that. You can hopefully see on my screen sort of 3 broad topics that I thought we could use as jumping off points for the conversation today. I get a lot of questions clinically about PrEP in the time of COVID, particularly around the notion of is it appropriate to extend the 3-month interval for testing or visits in the time of COVID where people are reluctant or can't come in for clinical visits, how to do STI testing in that context. If you find an active sexually transmitted infection, how do you get treatment accomplished in the COVID era, and what is sort of reasonable in those sort of contexts. Then I also get a lot of questions about when long-acting injectable PrEP is going to be available, concerns about the pharmacologic tail of long-acting PrEP, many things about the safety and acceptability of long-acting PrEP. And then the other large group of topics that I get asked about a lot is, how do we encourage people to continue to value condom use when we have highly effective PrEP products? And I think it's a nuanced and sometimes thorny discussion with patients. And people accuse us of sort of not knowing what people want and not appreciating what people are willing to accept as risk when we have those conversations. So it can sometimes get a little bit contentious. So I thought that would be a good topic for us to discuss also. So let me start by just sort of rambling a little bit about PrEP in the time of COVID. And anyone who has comments about that, please jump in on the chat, and or if you want to interrupt me and speak, that's also great. The CDC has basically come out with a statement that we should continue to attempt to do our 3-month follow-ups in the COVID era. And of course, depending on your local geography, people may not want to come out for those 3-month follow-ups. And people have asked a question about whether home testing could supplant some of that. In our practice, we've actually found that people want to come to the clinic for at least laboratory-based testing, and then sometimes with a video visit follow-up. And we've been able to do that in Los Angeles despite really high COVID rates. We're a COVID hotspot, as I'm sure many are aware, and some of you are likely in COVID hotspots also. But people have found the normalization of coming in for that testing to be reassuring, and people have not wanted to test to try and navigate the complexities of home-based testing, certainly for STIs, but also for HIV. And I'm wondering if anyone else has experience that's different from that with doing home-based STI testing, home-based HIV testing, how you document that, and then what you're doing about treatment. And anyone who wants to jump in, please do. Otherwise, I'm perfectly happy to keep blithering at you.
So my name is, oh, sorry.
No, go ahead.
Oh, so I never done home testing before. So actually, this is the first time I'm during the conference I hear about the home testing HIV and STIs for PrEP patients. So can you explain a little bit more about this?
Sure, sure. So there are some commercially available home-based tests. The OraQuick is one. There are some other manufacturers as well that people can purchase at local pharmacies. Some of them are oral swab tests, which have lower sensitivity. And some of them are actually home finger prick tests where there's a lancet included, and people essentially take a finger prick sample of blood and put it on either a dried blood spot piece of filter paper or into a fluid solution, and it's sent back centrally or in some cases read out locally after a timed interval. There are also some companies that will send you a packet that have a lancet, and you can do a finger prick uh, and put it on a piece of filter paper and send it into a central lab where it's tested on a machine or an instrument-based assay and has better reliability. So there are a number of different ways you can do it. Plush Care, Nurx are some of the companies that are doing it. There are likely others as well. The home STD testing is a little bit more involved, and I actually haven't tried it, and I'm not sure what people are finding in terms of commercial availability. I do know there are some commercial companies that are sending it as part of packets, but I haven't tried it myself. I see someone put in the chat that they've had patients take a screenshot of one of the home tests and use that as proof of testing. I think there's a variable willingness of providers to accept that because you can't, of course, guarantee that the sample was collected appropriately and people are concerned, but I think it's certainly better than nothing. And the other thing that gives me a lot of reassurance in accepting home-based testing, or even potentially accepting a slightly longer interval between testing episodes, at least for daily oral PrEP, is if someone has been clockwork reliable in the past and you're able to have a video visit and chat with them about their adherence. And if they say that they've been taking their PrEP daily, or if they use it on demand, that they've been using that with fidelity, and you have a long history with that patient, I think it's reasonable to extend that interval. The question is, how long would you be comfortable extending the interval? I've extended it at least a month, sometimes 2 months. I don't know that I would be comfortable going longer than 6 months without any form of testing, but I have pushed it past the 3-month interval for people that I have a long history with. We know that their renal function has been stable over time, and they've gotten their refills on time, suggesting at least reliability in their use. But it is a fraught discussion, and with people who are less consistent with their refill history, you do worry about potentially missing an incident HIV infection and then someone resuming PrEP in the context of actually being HIV infected. So I do get anxious about it. The other thing that I've been asked a lot by some patients is, well, during this time of social distancing, I'm not being as sexually active. In fact, I haven't been with anyone in X amount of time. Should I just come off PrEP entirely until things relax a little bit? And I find that actually almost as nuanced a conversation as is the conversation about whether you should push the window of testing any further, because what's true today might not be true tomorrow, and we certainly have seen clusters of STI and even HIV outbreaks during social distancing, where people who have been isolated um, and really missing social interaction and interpersonal sort of closeness so much that people are congregating and there are encounters happening, usually anonymous encounters, and people are going out and sometimes sheltering in place together. So I think it's really important to have as frank a conversation with people as you can about what the risk is, and making sure that they understand that you think it's really important that they get tested after a hiatus of PrEP before restarting. And sometimes it's difficult to anticipate when sexual activity is going to resume, even in the current sort of social distancing recommendations. Someone's also asking, what proportion of patients are on on-demand PrEP, and how comfortable are you with that, and for whom? It's a great question. We're becoming increasingly comfortable with it. It still doesn't have a US FDA or CDC recommendation, but last year, 2 years ago's, the 2018 IAS-USA guidelines do recommend it as an alternative for people who can predict their sexual activity. And I think we have increased experience with it from Europe and France in particular, where it's highly effective if you take it as directed. So if people are able to take the double dose of TDF FTC 2 to 24 hours before a planned sexual encounter and stick with that second dose of a single tablet 24 hours after the first one, and then that third dose 24 hours after the second one, we do have high rates of protection, high levels of effectiveness. So I do believe that it works. I think the real question is, is the person in front of you able to reliably anticipate when they're going to have sexual activity? So yes, I'm comfortable with it, and that's the for whom. And of course, the data is strongest for cisgender men who have sex with men. I'm less comfortable about it for transgender women, and there are no data about it for cisgender women for vaginal protection. So it is a somewhat rarefied population for whom I'm comfortable prescribing it. I suspect people may be doing it a lot more than we're hearing about, and I think it's geographically more popular in some regions than others. It's gotten a lot of attention in San Francisco and in New York, and I think less so in other regions. So in LA, I don't have a ton of people who are using it in that way, but I do have a ton of people who ask about it. They're sort of curious about it. So that's at least how I approach that. One thing that we get asked a lot is, how do you know when to bring someone in for testing if they're using 2-1-1 dosing, because it could be inconsistent. And I still bring people in every 3 months for testing. I don't change the interval of follow-up just because they might be using it on demand, just because I want to make sure I'm not missing any renal complications or missing an incident HIV or STI event. Someone asked, can you please speak to some of the challenges of PrEP in those who inject drugs? When do you do PEP to PrEP versus PrEP at the outset? If you know they had a high-risk exposure fairly recently, and long-acting PrEP in this population. So great questions. The data that we have to date is limited to a single study, right? And that's the Bangkok tenofovir study. We definitely need more data in people who inject drugs, because that Bangkok tenofovir study, if you look at it in a careful way, the protection was very limited when people were actually having ongoing injecting events during that study. And the 50% or 49% overall efficacy was only seen in the period of the study when very little injection behavior was going on. So of course, people who inject drugs also have sexual activity. So the real question is, was the protection in that tenofovir alone, not tenofovir emtricitabine based study, actually attributable to sexual risk protection and not to the parenteral exposure? So we definitely need better data. With that in hand, I always use 2 agents with people with injection drug use behavior. I don't use tenofovir by itself, despite that being what the randomized trial used. And the reason I do that is the added toxicity of the emtricitabine is negligible. And certainly the extra protection, not only against HIV, but theoretically against hepatitis B, gives me an extra measure of protection or confidence. When do you do PEP versus PrEP? I think if somebody, again, it depends what sort of baseline testing you're able to do. If you're able to do a viral load with your instrument-based fourth or fifth generation test up front before you start your antiviral based protection, or you're starting immediately, then I'm much more confident just starting a two-drug regimen, knowing that you're going to get the results of those much more sensitive tests back quickly. And if in fact they're positive, you can intensify. Another approach that some have advocated is if you have someone with a recent exposure, they don't have consistent with acute HIV infection, so nothing protean like fevers or sore throat or a rash or genital ulcers, lymphadenopathy. Of course, fully 30% of people may be completely asymptomatic during a acute HIV acquisition. So it's not a slam dunk that you know that they're not seroconverting. Some people will actually start someone on a 3-drug regimen until you get that testing back out of fear of generation of resistance, and then de-escalating to just a 2-drug PrEP-based regimen if those tests come back negative. Now that's fairly complicated. So the real question that I would ask is, what's your turnaround time for those more sensitive tests, and what sensitive tests are you able to do up front for someone with a recent exposure? If you're able to get a viral load turnaround in 24 to 48 hours, I don't think it's unreasonable to begin a 2-drug PrEP regimen and then intensify if you find that someone is in fact in the throes of acute HIV. It's unlikely that 48 to 72 hours of 2-drug therapy is going to generate resistance. But if you're really concerned and there's a known high-risk exposure, starting with a 3-drug regimen and then de-escalating, not unreasonable. Long-acting PrEP in that population might be really attractive, but right now the only data we have is for sexual transmission in cisgender men and transgender women. So, there are macaque challenge models of long-acting injectable cabotegravir in an injection drug use model, so parenteral exposures, suggesting that there's going to be efficacy, but we don't have human data yet. And of course, in the US, cabotegravir is not approved for any indication yet, right? It's either about to go back before the FDA or has already gone back to the FDA for its approval with long-acting rilpivirine for maintenance of virologic suppression in people living with HIV, but not for any prevention indication yet to date. I hope that's a helpful perspective. Many ways to approach this. Love to hear your approach. Chris, also, if you want to chime in and unmute yourself, I'll give you a second in case you want to do that, and then I'll move on to Wang's question.
Yeah, so hey, can you hear me?
Yes, we can.
Okay, so we deal with this a lot in our community, and we've really moved more aggressively toward same-day PrEP initiation as much as possible, because we found that from a practical standpoint, it was really hard to get buy-in from people to do 3 drugs straight off, unless they knew that they had a high-risk exposure within the last 72 hours, and they themselves were also very concerned about HIV acquisition in that setting. And like you, Rafi, I feel like the risk of developing drug resistance with a short-term exposure to 2 drugs is pretty low. I mean, the reality is, 20 years ago we were using 2 drugs, and it took a while for resistance to emerge, right? So I feel like as long as we are able to get our results within, I even extend the window 5 to 7 days, then I'm comfortable starting them on 2-drug PrEP.
Yeah, can I just ask, Chris, are you giving people the prescription the same day, or do you have sort of a pharmacy even in your clinic where you can dispense it, or how are you navigating that? Because we don't. And so what I tend to do is I send the testing and we get the results usually within 24 hours. And what I do is I then call the patient and then phone in the prescription, or if it's someone who's extremely sort of understands the risks and benefits, have them fill it that first day, but not start it until we get that testing back. But I agree, there's, you don't want to miss a window of opportunity for someone who's recurrently at risk, to protect them, because the worst thing you could do is, while you're sort of twiddling your thumbs trying to make sure that you're doing it perfectly, that you miss an opportunity to prevent an infection.
It depends on the setting. So I practice both in kind of a regular fixed clinic setting, but I also work a lot on our mobile health unit, working with our people who are unstably housed and who also suffer from substance use disorder. And in the latter setting, in the mobile setting, we give them the script the same day. So when they pick up their treatment for their opioid use disorder, they're picking up their PrEP script at the same time. In the clinic setting, it depends a little bit on the patient and their preference, where they live, how easy it is for them to get to the pharmacy, how likely it is for them to come back, how easy it is to connect with them and give them those follow-up results. So all of those are factors that that go into our decision making as to whether we just give them the script right then and there, or decide to wait for the results before we give them the script.
Yeah, I'm just curious, and in your population who you're giving treatment for substance use disorder in the same sort of visit, what sort of compliance are you getting with PrEP, or how are you sort of assessing that?
That's a great question. When we haven't, since COVID, we haven't done a great job of tracking our data. But initially, the uptake was like the PrEP persistence after 1 month was really low. Like only one patient out of the 20 or so that we had actually given PrEP prescriptions for. So it was very, very low. In the several months following, that it was higher, but again, we haven't had a chance to go back and analyze the data formally. So I think a lot of it depends on we found a lot of it depends on the specific individual and their own individual assessment of their ongoing risk, because as you mentioned, risk is not just from injection and drug using behaviors, but also from sexual behaviors. And that's one of the things that we really try to emphasize in our counseling when we're talking to people, that because we have found a lot of resistance up front about starting PrEP for patients who are coming also looking for treatment for their opioid use disorder, because they feel like, hey, that's a part of my life that I want to forget about. I'm turning a corner, and taking PrEP may be this unspoken acknowledgement that maybe I'm still engaging in these ongoing risk factors or risk behaviors. And what we try to be clear about is, look, there are many different ways that you can get HIV in our community right now. And if you're having sex with people, then that is one of the other ways that you can get it. So
that's fascinating. And I wonder then, in that particular context, whether a long-acting injectable PrEP medication, which could be administered in a visit and then not be a potential trigger to substance use relapse, might be particularly powerful.
Yeah, I think that there are a lot of potential advantages of the LA PrEP. I think there are some real potential downsides though, right? Because if you have somebody that you are, that had a possible exposure 5 days ago or 7 days ago, they're in that window period where it's not really indicated to give PEP, but you're not sure, the testing for acute HIV might not come back positive either. You give them the LA PrEP. Unlike the Truvada, the tenofovir FTC, it's a lot harder to stop that, right? You can't do anything once it's on board. So I think that there are those potential downsides. Yeah,
but at the same time, you also could then just add in a third drug.
You could add in a third drug, and that's a good point.
Yeah, I think we've got a lot to learn about how best to use it, and it's great that we're now going to have this additional option, but now we have to figure out a whole bunch of additional complexities. Right. So yeah.
Yeah, and adding in the third drug assumes that they're going to come back, though.
True. Absolutely true. But that's always the million-dollar question.
That is the challenge. So
yeah. No,
thank you so much.
Yeah.
Thanks.
And Huang, you were asking about for a bisexual male. So I'm gonna assume you mean a man who has sex with men and women. Would you start TAF or TDF, right? So the data for TAF FTC is really only was only done in cisgender men and transgender women who have sex with men. The FDA approval was generalized to any exposure except for vaginal exposures, right? So if you're talking about a male who's negative, who is bisexual, you know, probably the safest thing to do, where there's the most data, is to use TDF FTC, right? You could make an argument that he's going to never have a risk for that is not covered by the current FDA approval for TAF FTC, but we certainly have more data for an insertive partner, which is presumably his behavior with women, and when he has sex with other men, he may be both insertive and receptive partner. So I would be most comfortable using TDF FTC, but I think you could make an argument if there's an overwhelming reason that you thought TAF FTC were safer, that it probably would be okay for him, because the one mechanism that we don't have good data yet for its efficacy would be a receptive vaginal exposure.
Yeah, so
Jeremy had a question. Oh, sorry, Wayne, did you have a follow-up? I didn't mean to interrupt you.
I was asking a question because recently I had a patient, he was older guy, and he has comorbidity as well. His GFR is between 40 to 60. So so I started TAF because it was not sure, because I talked to my colleagues as well. They said it's okay to say kind of safe, but make sure patient also follow up with the PCPs as well, make sure check on kidney functions as well.
Yeah, for a creatinine clearance less than 60, TDF FTC says don't use it, right? So between 30 and 60, you really only have the option of TAF FTC. In that context, I do think it's reasonable to do that. Just remember also, I think you're right to make sure he's in close clinical follow-up, because TAF FTC is not renally offensive. It's just thought to be less renally offensive. And the question of, whether those differences are clinically significant or not is one that still remains to be answered, right? It's only these extremely sensitive markers of renal function that have better outcomes for the TAF compared to the TDF in the PrEP context. So I think it's only with more use and more extensive use that we're going to get a full picture about whether there actually are clinical differences. But it's true for the regulatory approvals, you really only have that one option in someone with a creatinine clearance under 60.
Thank you.
So thank you for that. Jeremy, you had raised your hand. Did you want to unmute yourself, or did you want to put something in the chat?
Yeah, thank you. Thanks for doing this, and I'll take the plunge and turn on the video too. So a couple of questions. First off, just some tough clinical questions about when to use TAF or not, and maybe that could lead into some conversations about what you have heard or what you know about further research for TAF for women and for other folks that it's not currently approved for, including, so I have a patient who's a transgender woman who just had a vaginoplasty, but also has renal insufficiency and wants to use TAF, but no, that's not indicated. So I'd love to hear your thoughts on that first.
Yeah, so there are ongoing studies in cisgender women that are designed to answer the question about vaginal protection. They are not comparative studies, right? So they're going to be trying to establish efficacy compared to counterfactuals. So hopefully we'll have the answers to efficacy soon. I'm not sure what soon means. I'm going to guess 2021 is probably when we're going to see those data. And then the other side issue that you asked about is, right, someone who's a transgender woman who's had a vaginoplasty. And so I would break that into two questions, right? Because the first is, are they having rectal sex still? Is that their predominant mode of having intercourse? And what are they doing with the vagina, and what is the vaginal tissue made of? We have precious little data for transgender individuals, even with TDF FTC. So we have even less information about what happens in a neovagina. And if it's colonic tissue, you might actually be slightly more inclined to believe that there would be protective efficacy for this neovaginal exposure, because we know the components of TDF and FTC get into rectal tissue better than true vaginal tissue. But if it's scrotal tissue that's used to create a neovagina, we have no data about that. And I would be very anxious about the tissue level protection that you would get there. So I think it's a complicated question. For rectal exposures in a transgender woman, whose creatinine clearance was less than 60, I think it probably would be not unreasonable to use TAF, assuming that there was real protection. I would be a little anxious just because, right, there are these data with TDF and FTC, knowing that people on estrogens and estrogen anti-androgen combinations do have slightly lower levels in the plasma of tenofovir when they use TDF FTC. And we don't have those data with TAF FTC yet. So I certainly would encourage as rigorous daily adherence as possible. I would not endorse 211 kind of use in that setting. I would be a little anxious about it, but if you're stuck between a rock and a hard place, one thing you could do is use the TDF FTC and monitor the renal function more closely. Or you could, just with the caveats of we just don't know, the TAF FTC might not be unreasonable in that setting. Do you know what the neovagina is made of in your patient's case?
Yeah, I don't. And I do know that she wishes to engage in both rectal and vaginal sex. So I did know that. We talked about that a little bit, but yeah, that's something I can definitely investigate a little bit.
Yeah, just we know nothing about scrotal tissue penetration when used as a neovagina, and then even when it's sort of repositioned, then what its blood supply remains as clearly it's viable. So it has one, but how well the components get in there is an unanswered question. And then I think you bring up a much larger sort of issue of we need better data for all of these agents in transgender individuals, and not just pharmacokinetic drug-drug interaction, but actual efficacy data, because it's very hard to confidently assure people that they're going to be protected when the studies haven't been done. And we want buy-in from our most vulnerable populations, and yet we don't acquire the data to provide that confidence. And so it doesn't really inspire confidence in the healthcare system when you say, we don't know, we hope this works, right? So I apologize. I wish I could give you more definitive answers. People are working right now to get some of those answers in transgender individuals, but we don't have the data yet.
Thank you. That was super helpful. I had one other question, a little bit different, going to long-acting injectables. I know yesterday we talked a lot about this with in terms of maintenance of HIV and the concern for covering the tail. And I just wonder about that with PrEP as well, and what thoughts are and going forward.
Yeah, with cabotegravir, the tail is long, right? The mean time to undetectable concentration of cabotegravir for someone who's born male is about 44 weeks. And the mean time for someone born female is about 65 weeks. And there's enormous variability in there. The longest that we estimated in the phase 2 study of cabotegravir PrEP for a male was almost 3 years. And for females, it was almost 4.5 years. So that's a really long time. And so the question that I always come back to is someone who is stopping a long-acting injectable for PrEP still at risk for HIV? If they are, then they absolutely need something else to supplant that. Whether it has to be a daily oral PrEP regimen, that's the only thing that we have from a biomedical standpoint to offer people. But to me, the real question is, if they're ongoing at risk, we need to leverage every HIV prevention mechanism we have to keep someone negative. It doesn't so much matter what, it matters that we pull out everything that they're willing to use. Is that condoms? Is that daily oral TDF FTC or TAF FTC in the right context? Is it the dapivirine vaginal ring in women in sub-Saharan Africa that now has an EMA approval? Is it, having conversations with people about, their status and just harm reduction? Is that all they're willing to do? Whatever we can leverage people to use to keep themselves HIV uninfected, we need to do if they're still at risk. If they're coming off the injectable PrEP because they're no longer at risk, then in theory it shouldn't matter, right? So that's how I think about it. One thing people have asked me is the pill-based version of cabotegravir going to be an option, right? Suppose someone doesn't want to use, a tenofovir-based PrEP agent, and they did the oral lead-in, and now they did the injectable. They didn't like the injectable. They want to stop the injectable. Can they go back to the pill-based cabotegravir, to cover that tail? And it's an interesting question. From everything I've heard from our counterparts at ViiV, they are not planning to seek a regulatory approval for the pill version of cabotegravir for PrEP. So probably that's going to be an unregulatory approved manifestation. And probably the best recommendation is going to be, if you want to leverage a biomedical prevention strategy to cover someone ongoing at risk while the tail's washing out, it's going to be a tenofovir-based preparation. What the consequences are of seroconverting during that tail still remain to be determined, right? Of course, what we all have incredible anxiety about is, do you then get integrase-resistant virus that then might not also retain susceptibility to things like dolutegravir or bictegravir? And we don't know the answer to that question yet, right? I mean, a lot of these dolutegravir failures in HIV treatment are, number one, vanishingly rare, and then sometimes don't have resistance to integrase. So I don't think we know enough about the cabotegravir quote unquote failure resistance profile yet to know, but it's something we clearly need to define, because what you don't want is to lose options for simple one tablet treatment options if someone does acquire HIV in that context. So I think it's a critical question. I think we just don't know right now. And I fear that the phase 3 trials aren't going to answer that. I think even the open label extensions that likely will follow, there won't be enough events for us to answer that. It's only going to be when we start ramping up its use after, we hope, regulatory approvals, that we're going to begin to get a sense of that. If you remember back with Truvada, right, it wasn't until there was substantial scale up that we started hearing these cases of people, despite good adherence, seroconverting anyway, and sometimes transmitted resistance, sometimes high exposure rates in the context of ulcerative STIs. So it's really only going to be with really increased rates of use that we're going to be able to define this. And hopefully it's going to be sufficiently effective that this is going to be a rare event, but we certainly need to describe it and understand it. That was a really long answer to a question that was way more probably than you wanted to talk about. So I apologize for that. Okay. Other thoughts or questions about that? We've now gotten through two. No, yes, go ahead, please.
Hi, this is Joyce Jones. I'm a physician at Johns Hopkins at the Bartlett practice. And this is related to using telemedicine for PrEP. And I just wanted to mention that one of the things that we did is with LabCorp, with our local LabCorp, we can have them send home self-test kits for gonorrhea or pharyngeal gonorrhea and rectal and vaginal self-swab. So, you know, I've been doing video visits, and then I place an order from LabCorp, and then at the patient's convenience, they can get the self-swab kits mailed to them. They go to the LabCorp, drop off their swabs, and then they can do the other testing as well. So that's one of the things that we put in place. It still requires them to go to a medical setting, but it's a little bit more convenient. And then we do have at Hopkins, and actually through a relationship with the Baltimore City Health Department, there's I Want the Kit, which Charlotte Gatos has been doing the home-based testing. So that's another option for patients, is they can, and actually it's anybody right now in Maryland, anyone can request a home-based gonorrhea, chlamydia, extragenital testing kit. And then they get the kit, they perform the self-swab, they mail it in, and then the lab at Hopkins runs the test, and then the patient goes to the website to get their results. In Baltimore City, they're also offering OraQuick. So not a great test, but still, that's also available. That's all for free, again, through a relationship with the City Health Department and the Maryland Department of Health.
That's amazing. That sounds like you've got a very on top of things health department. Could you talk a little bit more about home pharyngeal swabbing? I mean, self-swabbing for rectal processes we're fairly comfortable with. I've not seen a lot about self-oral swabbing.
Yeah, I mean, so our lab, I Want the Kit lab, did do the validation, you know, in terms of ensuring that whatever the individual collects themselves is this same result as the clinician collected. And then that's with LabCorp Aptima, now that it's been approved, that's why LabCorp can do the extragenital testing using the Aptima swabs. So
right.
We mail out, with my patients, I've been counseling them with the telemedicine visits about the self-collection, and then we mail a handout with it to sort of show them how to collect. Probably a good thing to do, which I haven't done, is to ask them, you know, if they have problems with collecting it, to let me know, you know, so that I can be more assured of what's the quality of the specimen collection. But we just, with LabCorp, that's a new thing. So I've been piloting it with a few patients. I had a positive result as a result of the self-collection just recently. So yeah.
That's great. I didn't realize LabCorp was doing that. Do you know if that's just a local program that they're doing in your area, or if that's sort of nationally available from them?
So because the Aptima swab is now FDA approved for all of the extragenital testing, that opens it up for all of the labs, right? So, but you know, with any non-FDA approved test, you would have to do the local lab validation. So now that the Aptima has been approved, if you have a lab that will run that test, then that is okay to do. So then you have to talk to your local lab. So Whitman Walker apparently had been made this arrangement with LabCorp quite some time ago. So then we talked to our local rep. Ideally, what I was thinking is that, you know, how people go and self-collect urine, that you would do the same thing within the lab testing site. They said that there were some issues with that. I'm not exactly sure what the problem is, but they were looking into it to be able to, within the lab's facility itself, do the self-collection. But in the interim, our local LabCorp has been great. I mean, to be willing to mail the kits out to the patient. So I think if you have a good relationship with your local lab, or even, you know, one of the things we're doing at Hopkins is they don't use the Aptima test, they use a different platform. So we're going through the process of the validation so that patients who go to a Hopkins lab would be able to do the self-swab.
But that's great. I didn't, it sounds like there may be a little finessing that needs to be put in place with a local LabCorp to get them to be willing to provide the swabs either home or in unit, right? Once there's an FDA clearance of a test, they can run it. But the question has always been acquisition, right?
Right, and again, this was through I did this in conjunction with the health department. Their STD clinics had been trying to put this in place, and they already have a good relationship with the LabCorp rep. So we kind of collectively went and made this request, and they made it happen.
So let me ask you, when you got a positive test back, what were your options for getting people treated? Did you send them to local health department? Were you able to bring them in to your clinic, or how did you intervene?
So we're doing that treatment in our clinic. So,
Okay.
early on I had empirically treated some individuals with oral, but, I feel like we sort of know more about transmission. I'm feeling more comfortable about the things we've put in place to prevent transmission within our clinic. Obviously, transportation to the clinic is something to consider, but from my perspective, this is important enough that having someone come in for treatment is warranted. So that's what I did with this most recent patient.
Yeah, thanks, Joyce. I mean, I've gotten questions from other providers of, if someone won't come in, and what's your comfortability with doing doxy as first line for syphilis, or cefixime, with the Zithro, for gonorrhea, and or taking a risk with a quinolone and retesting. So people at least in various times during this pandemic have had varying degrees of comfortability. I agree with you that it's probably worth trying to find a way to do it right. But if people don't have private transportation, sometimes it can get really fraught.
Yeah, agreed. And so then, the oral would be the next option. The other thing, that our pharmacists, one of our pharmacists in the clinic, along with others, they're trying to get the state to change the laws, and this is different by state, about what can happen in pharmacies. So that is another option, is if you could give that treatment. And again, the transportation, that issue doesn't go away, but that at least they wouldn't have to travel so far, right? And that's the same idea with the LabCorp. If there's a local space where the travel is less extensive, it's more convenient. Also, with the economy being the way it is, if people are traveling, long distances to get treatment. So I think it varies by state, whether or not within a pharmacy you could give these medications. So that's something else that we're trying to change.
Yeah, I think it's a brilliant idea, because most people have some sort of pharmacy, closer within their communities, so that getting there would be easier. It all depends what's allowable, right? I mean, in California, we now have a law that says that pharmacists actually can prescribe PrEP, but the mechanism to operationalize that has not been put in place yet. So I have not heard of any pharmacies that are actually successful in doing that. But I think the more we can move towards protocolizing and non-medicalizing these interventions, the more acceptable they're going to be, and easier to get. Particularly, this isn't going to be our only challenge, right? We'll get through this, and then there'll be something else that will make it challenging to provide prevention services or treatment for STIs.
Right.
Complicated, but thanks for that information about LabCorp. It's great. And I know I'm going to look into my local LabCorp and see if they're going to be willing to send things out to people. So I think that's great. Thanks for sharing that. We have a couple minutes left. We're supposed to stop at 10 after the hour so that people can get back to the main room, and then have a little bit of a break before before the case-based discussion. How are people talking to folks about condom use in the current era? Because when we claim that PrEP is so highly protective against HIV, and we tell people that we want them to still use condoms, and the ostensible reason being, number one, no prevention mechanism is perfect, and number two, the bacterial STI and other STIs that are not curable still exist. People sort of accuse us of being duplicitous and saying, well, do you believe that PrEP works or not? And it ends up being a little bit of a nuanced discussion. I'm just wondering how people are approaching that. It's because it's challenging. Anyone want to jump into that pit of mud, or not enough time in the day to get into that?
Oh, for my opinion,
Voice, come on. Oh, sorry,
Okay.
Wang, were you going to say something?
Oh, I said, like, when patients initially start PrEP, I always emphasize the importance with the first 21 days they use the condoms, to wait for the medication to get into the bloodstream to have, to certain levels. So from starting there, I say, emphasize the importance of condom use, in after 21 days, still important to prevent STIs.
So you just brought up an interesting point. The question is, what is the onset of protection of PrEP? And when the guidelines first came out, the most conservative measure was 21 days. The PK modeling now for rectal protection with TDF-FTC suggests 5 to 7 days, actually. And some of the PK modeling even suggests for vaginal protection that also is true, that by 7 days you likely have maximum levels of protection. We don't know for parenteral exposures what that answer is, but if you look at the IPERGAY data, the 211 data, it actually suggests that if you do a double dose of TDF-FTC up front, you could get rectal protection within 24 hours. So I think we may be seeing a movement in guidelines going forward that even when people are planning to use daily, at least TDF-FTC, that you should actually start with a 2-dose load to get protection on board faster, that you may then get protection 24 hours after that double dose and then go to single doses thereafter. So I think it's going to be very interesting. I think that's a very fast moving field. So just wanted to make that comment as we sort of talk about 21 days or not. But I do think it's a difficult conversation to talk about STIs. So Dr. Adams says, I always talk about condom use in the sense of protecting oneself from STI, lots of syphilis in the area, and Joyce agrees. Yeah, I mean, I think, we're in the middle of an epidemic also of bacterial STIs. I think, here in Los Angeles, we have a population who's just not afraid of that. And, you don't want to be fear mongering, but pointing out that there is increasing resistance and treatments getting more difficult doesn't seem to be carrying a lot of weight with people. So it's been a challenging conversation here in Los Angeles, I will say that. Okay. Well, we're at the end of our time together. I want to really thank everyone who chimed in and everyone who was listening and participating as we went along. Hopefully this was interesting, useful, at least a little bit. And please, everyone, go have a good bio break. And we'll be doing some cases that will talk about some of these issues in a little bit more detail in the large session when we get back. Thanks, everyone.